Hi everybody. We're going to talk about sepsis, and what we're going to talk about is the pathology of sepsis. And we need to do this prior to talking about the coding of sepsis or the sequencing of the codes of sepsis, because if you don't understand the pathology, you're not going to be able to code it. If you don't understand how it affects the body, what it actually is, because there are very specific criteria that have to be met in order to deal with sepsis, okay? So, the first thing, and I've got some notes here, so you're going to see me looking down and looking back up. I just want to make sure that I get the information to you correctly, okay? So, what is sepsis? First of all, we have to talk about what is sepsis. Sepsis is just a condition where your immune system in your body just kind of goes into overdrive. It just kicks right in and it releases a whole bunch of chemicals, and those chemicals trigger an inflammatory response in your body in order to defend itself against infection. So basically what happens is your whole body is just kind of going, wah! Okay? It's just going cuckoo, all right? So there are 4 different levels of sepsis that have been identified. Okay, the first one is systemic inflammatory response syndrome, or SIRS. Now, SIRS can be in response to a non-confirmed. It can be in response to something other than a confirmed or non-confirmed infectious process. Meaning, what do I mean by that? Means that you could have no infection, but it could be in response to a major trauma or a severe burn. Many times, we all watch those medical TV shows, and a lot of times they'll just say, they've got somebody that's been in a bad car accident or something. Oh my gosh, the patient's going into shock. Shock is just a catch-all term. It's kind of like, there are so many different types of shock. There's hypovolemic shock, where they don't have enough fluid. They've rapidly lost fluids from their bodies very quickly. There's cardiogenic shock, where the heart's in shock. So one of these is the systemic inflammatory response syndrome. And the criteria that has to be met in order for this to be diagnosed is very specific. Okay, so we're going to go over it really quickly. Number 1, hypothermia. Patient's temperature has to be lower than 97 degrees Fahrenheit or 36 degrees Celsius, or they can have a fever higher than 100 degrees Fahrenheit or 38 degrees Celsius. Okay, and you may want to make notation of both Celsius and Fahrenheit, because in medicine we use both. Okay. Tachycardia. We all know what tachycardia is, right? It's an increased heart rate. So that's your heart rate greater than 100 beats per minute. So not 99, not 98, 100 beats or higher than 100 beats per minute. So 101 and above. Okay. Tachypnea is where we're doing what? We're breathing too fast. Tachypnea, right? Okay. That's more than 20 breaths per minute, meaning more than 20 inhale and outhale. That is tachypnea. Okay. Then there's hypocapnia, and this is where your arterial CO2 is going to be less than 32, which means you're going to have to look at some labs here. So what you're going to be looking for is any of that criteria in a patient's record. Is it met? If they have trauma, if they have, a burn, something, I would look for this. Okay. Here's the key: a patient only needs to meet two or more of that criteria in order to have a diagnosis of SIRS. So if you see a patient meets 2 or more of those, then you need to do what? Query your doctor. Yeah, okay. You need to ask him, what's the clinical significance, and list all of those, okay? The next type of sepsis we have is SIRS. It's sepsis, which is SIRS in response to a confirmed infectious process, which means we actually do have infection. Our SIRS now is not due to trauma. It's not due to a burn. We know that it is due to an infectious process. And how do we know that? Typically, those infectious processes are either localized infections or postoperative infections. So, what do I mean by localized? the patient has pneumonia. It's very common. We see it with patients. That's one of the reasons pneumonia can be so dangerous. Pneumonia can become septic very quickly. Okay. Cellulitis is one. That's just a localized, excuse me, a localized infection in the body somewhere in the tissue, right? So that means that we know we've got a confirmed infectious process going on somewhere in the body locally that has now become septic. It's caused it to go systemic. Okay, it's caused SIRS. Postoperative infection, what do we mean by that? We mean that within 10 days of a postoperative procedure, or 10 days of a procedure, a patient has become septic with an infection. So that area got infected, something happened, and boom, we suddenly see SIRS. All right? Then we have severe sepsis. That's number 3. And what do we mean by severe sepsis? That's sepsis plus organ failure or organ dysfunction. So if you really look at these, they're building on each other, aren't they? First we have SIRS, and SIRS is just due to trauma or some type of burn or something that's going on like that in the body. Something that's happened, an insult to the body. Then we have sepsis, which is SIRS with another layer. We know we have a confirmed infection somewhere, okay? Now we have septic shock, severe sepsis, which is sepsis, which we know is SIRS, right? Sepsis with organ dysfunction. So we could have someone who has pneumonia, and they've become septic, so they have severe sepsis. So they have sepsis in response to a localized infection of pneumonia, and now their kidneys are starting to shut down, or their liver is starting to shut down, or both. We could have multiple organ failure, okay? That is going to be severe sepsis. The last one that we have, number 4, is septic shock. Now, septic shock is the same thing as severe sepsis, except the organ dysfunction that is included, or one of them that is included, is the circulatory system. We have circulatory system failure, which basically means what? When we say circulatory system, what's the first thing we think of? The old ticker, right? So that means that the heart is not working. If the heart's not working, ain't nothing working, right? Okay? So that's when you see septic shock, all right? The next thing we need to talk about is how do we usually test to see if someone is septic, if they have sepsis? Most of the time you will see that the physician will order blood cultures. Now, we all know that blood cultures, or we should know, I hope, the blood cultures are where we draw the blood at certain time intervals, and they culture the blood just like they would for a urine culture. They put it in the petri dish, and they grow different things, right? Okay, to see if anything grows. And if something grows, then you probably have sepsis, because nothing should be growing in there, right? Not anything. There shouldn't be any bacteria in your bloodstream. Okay, now, just because you see that a patient has negative blood cultures and the doctor says sepsis does not mean the patient doesn't have sepsis. So what I'm telling you is negative blood cultures do not preclude a diagnosis of sepsis of any kind, okay? A patient could have negative blood cultures and still be septic, because they could still have SIRS in response to something going on in their body, right? Okay? So, just kind of keep those things in mind. If you're in doubt, talk to your physician, okay? But that's what you have to understand. And if you need help keeping that straight, write yourself a note, because when you're coding, this is going to be really, really, really important, okay? Trust me on this. All right. Talk to you later.